Okay, so we're just a few shy seconds away from the top of the hour, but we've got a lot to cover today. So again, I want to take the opportunity to welcome you to this second in our four-part series on opioid use disorder, specifically geared towards licensed nursing home staff. We do have others in our series, and we hope you join us for those future events. My name is Toni Kettner, and I'm joined by my colleague Stacy Koop. We are both quality improvement advisors and work exclusively in Superior Health with nursing homes. So again, we're excited that you could join us today. Just a couple of things. We will be allowing the opportunity to ask questions, but if you think of something as Dr. Redwood is speaking, please be sure to put that in the chat, and then there'll be an opportunity for him to address those following the discussion. There'll also be an opportunity for you to ask a live question if you would choose to do that at the end of the discussion. And then before I turn it over to him, just one more reminder, we will be posting a form for you, an evaluation form, and it takes about a minute to complete. We really appreciate it when you complete those because that helps guide us in future work and lets us know what other topics are really important to you. So look for that as well. So without further ado, Dr. Redwood, I'll turn it over to you. Thank you.
Thank you, Toni. Thank you, Stacy. Thrilled to be here today, of course. I'm going to share screen and get us started. My name is Bobby Redwood. I'm an emergency physician and preventive medicine physician. That's the medical specialty of public health. And I'm very passionate about opioid use disorder and really curbing this epidemic. I have made it my life's work. We see a lot of blue patients in the emergency department. We try to turn them pink by reversing their overdose. We're not always successful. And we'll talk about it, but we're really seeing with this silver tsunami, also a tsunami of opioid use disorder and people living longer. You know, we now have buprenorphine, which is the topic of this webinar, buprenorphine in long-term care settings. And when we had methadone alone to curb cravings, it was very inconvenient to get to methadone clinics. There might not be a methadone clinic available in your area. With buprenorphine, it is a total game changer. This is a prescription medication. It can be sent by mail. It can be used at critical access settings, rural settings, and we are seeing people survive much longer with opioid use disorder. In fact, maintained for life on buprenorphine. Of course, that means that people are going to be in long-term care settings as geriatric patients, but also in rehab settings or skilled nursing facilities because of comorbidities related to opioid use disorder, whether that's bloodborne illnesses or skin sores from injection drug use, traumas from impaired driving, etc. So there's a lot of comorbidities associated with having opioid use disorder. And as people survive into their 60s, 70s, 80s with this disease, you're going to see a lot more patients on buprenorphine. So my hope today is that we can help guide you through some of the opportunities in giving best care for patients who are maintained on buprenorphine. And we'll also talk about reducing overdose, which is a possibility with this medication, although much less so than with opioid pain medications. This is me. I have no financial disclosures. And again, today we'll talk about what buprenorphine is, how it works. We'll talk about the role of long-term staff in treating patients who are on buprenorphine, how to recognize an overdose and how to administer naloxone, which is really a huge part of in the fentanyl era. We're seeing overdoses on very low, very early in the disease course. And so if somebody did have, for example, a traumatic injury, they're in a short-term rehab or a long-term rehab for that, and they were on opioid pain medications, we see pressed fentanyl pills, all sorts of pain medications that are just very easily transportable, brought in by family members. It's not unrealistic that you would see an opioid overdose in your care setting. And then we'll talk a bit about stigma at the end to make sure that we are putting our best foot forward in terms of welcoming patients into the medical environment and treating opioid use disorder as the medical disease that it is, not as a moral weakness or some sort of choice that the patient made that landed them in their current situation. This is just a history of the opioid epidemic here. It started with prescription opioids in the 2000s. We had the heroin era from 2010 to 2015. That was the peak of my training. And we really didn't see a lot of old heroin addicts. People died after 20 or 30 years of heroin use because methadone was hard to access and because there were a lot of comorbidities with injection drug use. We're now in the fentanyl era, and this spiral is showing you opioid overdose deaths, But think about the people who have opioid use disorder, if this is the number of deaths. So this epidemic is really just ballooning, unfortunately, and we're going to see a lot more patients with this disease and hopefully maintained on buprenorphine. That is the treatment for opioid use disorder. If you look at potency of opioids to the side there, morphine is 1x. Look at the fentanyl that we're seeing, 50 to 100x. And that is such a broad range, which really tells us why we're having so many overdoses here, is because if someone buys a pressed pill that looks like an oxycodone pill, but is actually a fentanyl pill, they have no idea how much drug is in that pill. And we see these pills being shared. We see them being distributed to people. Obviously, fentanyl's not prescribed, but pressed pills being distributed among acquaintances. I had a patient driving an ice truck the other day in the emergency department. He threw his back out moving a big block of ice, and he drove up onto the curb. He basically had an overdose, was found blue on the steering wheel, leaning on the horn. Thank goodness he was leaning on the horn. And someone came out and found him apneic behind the wheel. I really believe this gentleman. He said it was his first time he had ever taken an opioid. His friend gave him a Percocet pill, quote unquote Percocet, and it was a pressed fentanyl pill. So he overdosed and nearly died on his very first use ever. Kind of terrifying. And then if you look at the deaths, it looks like this for every state. Wisconsin's not an exception, but we are really seeing just skyrocketing diagnosis of opioid use disorder and skyrocketing overdose deaths. And the reason I put this is because death is also a proximity for comorbidities from this, right? When we see the deaths, think about the people who didn't die, but maybe they have a noxic brain injury. Maybe they crash their car and have a traumatic injury after that. Maybe they're injecting fentanyl and have skin sores and abscesses and bloodborne illnesses from that. All of these things are going to land you in a long-term care setting. So there's just a lot of mortality from this disease, but a lot of morbidity as well. Now, if you look at the literature citations below, we know that rates of opioid use disorder and overdoses are increasing substantially among older adults. So this is not a disease of the youth. And it really doesn't discriminate across socioeconomic status, income strata, race, gender. This disease does not discriminate. And then along with the high morbidity associated with opioid use disorder, we're seeing more opioid-related acute care use and hospitalizations, especially infectious disease complications, whether that's endocarditis, skin infection. These are just ramping up, not down. And again, the comorbidities that go along with that. Think about multi-drug resistant organisms, patients who get frequent infections. They're in and out of the hospital for sepsis, they're in and out of the hospital for surgical drainages, and the complications that come along with that. When someone has sepsis, they don't just bounce back, right? They have post-sepsis syndrome, they're weak, they need rehab, they need occupational therapy, just a lot of long-term care needs. And then 16% of all patients discharged from hospitals with opioid use disorder are actually discharged to skilled nursing facilities. So if you're not seeing this in your care setting yet, you are certainly going to see it in the future. So we should all be prepared, which is why I applaud you for showing up today to this presentation. Let's dive right into buprenorphine, the treatment for opioid use disorder. These are the FDA varieties of MOUD, or medications for opioid use disorder. And buprenorphine really is the one that we're going to focus on today. Naloxone at the bottom is a rescue agent. It's a rescue agent for overdose. So that's something that you want to have kind of like an EpiPen for anaphylaxis, but you're not taking on a daily basis. Extended release naltrexone can prevent cravings. There's certainly a role for this in opioid use disorder. It's not yet generic. So it's quite expensive. It's a monthly injection. I think we'll be hearing much more about naltrexone in the years to come, but right now buprenorphine is the huge emphasis. And then methadone is for people who are on really King Kong doses of opioids, 200 plus milligrams of oxycodone a day. There is a role for methadone, but for people who have kind of garden variety opioid use disorder, it's more buprenorphine. It's just that much more convenient. You can go to your primary care physician, treat your hypertension, treat your diabetes, treat your opioid use disorder. That is the model, is to welcome this disease into all the other, chronic care diseases that we treat on a daily basis. The really amazing thing about buprenorphine is it gives you triple protection. And we're going to talk about this in the next slide. But buprenorphine it doesn't give you euphoria. It maintains your cravings. It is not able to overdose on buprenorphine if it has the Suboxone combination product, which includes buprenorphine and naloxone in the same product. And then it's not really diverted for euphoria because people don't get euphoric on it. So when buprenorphine is diverted, when people sell it on the street, and it does have a street value, it's actually to treat opioid use disorder. There are all these people out there who can't get treatment in the medical setting because of the stigma around this disease. I'm a physician. If I have opioid use disorder and I admit it to my state medical board, I can't practice in the emergency department anymore. So I would have an incentive to actually get buprenorphine off the street to treat my cravings so that I could live a healthy, productive life and not spend all of my waking hours seeking opioids. This is how buprenorphine works. If you look on the left, you have heroin. That's your full agonist. So that pentagon there binds to the binding site in the body. It has the shallow area of the pyramid that treats pain and reduces cravings. And then it has the pointy part of the pyramid. That's what gives people euphoria. If you look at naloxone on the far right, this is a full antagonist. This is going to knock any opioid off of its receptor, but it also throws people into withdrawal. So if someone overdoses on fentanyl, for example, and you give them naloxone, sure, they wake up, they start breathing again. That's the point. But they're also nauseous, they're tachycardic, they're pouring sweat, profoundly anxious. Buprenorphine is that sweet spot in the middle. So when you're on buprenorphine, you're, it's going to knock off Percocet, Dilaudid, fentanyl, anything like that. It's going to maintain your cravings, which is really the nastiest part of opioid use disorder. That's a nasty part of the disease, is the behavior surrounding the intense cravings associated with it. And it is not going to give patients euphoria. And so, if you had a truly opioid naive patient, someone who's never had an opioid, and you gave them multiple tabs of buprenorphine, there would probably be some mild euphoric effect. But with all the other full agonists out there, fentanyl, Percocet, Dilaudid, oxycodone, people are not using buprenorphine as a drug of abuse. They're using it to treat their cravings. And then there's a bit of pharmacologic jujitsu here. When you match buprenorphine and Suboxone, and naloxone, this combination product, the commercial name is Suboxone, but there's also generic forms available, basically is you can't get high off it at all. Because if anyone were to try to crush it or snort it or inject it, they would get the naloxone effect, which would prevent them from being euphoric. Could actually throw them into withdrawal if they were using other opioids. So this is a really amazing medication. It's revolutionary in the treatment of opioid use disorder. And you're going to be seeing a lot of patients on buprenorphine because up until last year, you had to have a special DEA X waiver. You had to have special training and special designation on your license in order to prescribe buprenorphine. And the X waiver is gone. Congress recognized that that was a barrier to treating opioid use disorder, and now anyone with a DEA can prescribe buprenorphine. And I do trainings on a weekly basis across the nation to med staff, showing them how to prescribe buprenorphine, the importance of prescribing it. We're really pushing this for good reason. You saw all those overdose deaths. This is the way to maintain people's cravings and extend their life. In medicine, we talk about the number needed to treat. The number needed to treat for buprenorphine is 3, meaning if we maintain 3 patients on buprenorphine, we save a life. There is no other number needed to treat like that in human medicine. The best number needed to treat that I know of after buprenorphine is aspirin for myocardial infarction. If you give 21 patients who had a heart attack a baby aspirin, you will save 1 life. Buprenorphine, the number is 3. And this chart just shows that. The longer patients are on buprenorphine, the more likely they are to survive. And if they're on buprenorphine for 100 weeks, 2 years, they have the exact same survivability as you or I or someone without opioid use disorder. Now, if you see, it doesn't actually happen immediately. You have to be maintained on buprenorphine for 25, 30, 40 weeks before you start seeing that survival benefit. That's because when people start buprenorphine, their lives are still a mess. They might be in jail. They might not have Medicaid coverage. Maybe their marriage has fallen apart. Maybe they lost custody of their kids. They don't have a job. All of these things are the collateral damage of the cravings associated with opioid use disorder. But when you treat those cravings, you're on buprenorphine for 5 weeks, 10 weeks, maybe you start going to NA meetings. Maybe you get Medicaid established. Maybe you finally get set up with secure housing and a job. And finally, when people build a life, they now have coping strategies. So when the inevitable horrible thing happens to you, which is, that's life, it's going to happen to all of us, they don't turn to opioids to treat their stress, but they actually have healthy stress techniques. They can go see their peer recovery coach. They can go see their counselor. They can see their primary care physician and talk about what to do in relapse planning. There's a lot of good that has to do with this medication after the cravings have been treated for a long term. This is how I prescribe buprenorphine and how most people prescribe buprenorphine. I think it's important just to know how we use it. We basically wait for someone to be in withdrawal. So you don't start buprenorphine when someone is actively using in general. There is actually a macro dosing way to start it, but in general, we wait for people to be withdrawing. For fentanyl and short-acting opioids, that's actually 6 to 12 hours. And then for something like fentanyl patches, OxyContin, or methadone, it's 30 hours plus for withdrawal. But we have a scoring system, and we wait until patient is in peak withdrawal and then start buprenorphine. This is what it looks like. One thing you should know is buprenorphine and Suboxone dissolve under the tongue slowly. It takes like 10 to 15 minutes for these medications to dissolve. And so if patients kind of start them withdrawing and then swallow, they won't get the full effect. So if your patient is unfamiliar with these for some reason, or they're just getting started, you want to emphasize that it actually takes a long time for these to dissolve under the tongue. It's not like Zofran that dissolves in 1 to 2 minutes. And then when someone comes in withdrawal, I start them on buprenorphine. First 4 milligrams, I wait 30 minutes, then 8 milligrams, I wait 30 minutes, then 4 more milligrams until their withdrawal is essentially treated. They say, I don't feel like I'm withdrawing. I feel good. And that is their maintenance dose. So if you came into my emergency department and you were withdrawing from fentanyl, and I gave you 16 milligrams of buprenorphine until you felt better, your maintenance dose would be 8 milligrams twice daily. And that's what most of your patients are going to be on. 6 milligrams twice daily, 8 milligrams twice daily. Those would be very common doses. And then one thing I should say is, if someone's transferred to your long-term care center or your rehab and they do not have your buprenorphine, they will absolutely go into withdrawal. And so part of good treatment is having a very safe handoff where you confirm with wherever the patient's coming from, if they're coming from clinic, if they're coming from a hospital setting, is that they have their buprenorphine with them or you're able to get it to them in a timely fashion. Mail order medications on a Friday, one of them's buprenorphine, and that patient's about to run out. That is actually kind of a problem. You might need a bridge prescription from the ED or some sort of solution where you can make sure the patient has their medication. Let's dive right into naloxone. Like I said, naloxone is the EpiPen for opioid use disorder. This is how you turn blue people pink. So if you come into a resident's room and you see pinpoint pupils, if you see blue fingertips, blue lips, if you notice that they're very bradycardic, their breathing is extremely slow, if you can't wake them up, and they have opioids prescribed to them, this would be very concerning for an opioid overdose. Now, like I said, it is quite hard to overdose on buprenorphine. Buprenorphine offers protection from overdose. So if you had someone taking buprenorphine, I don't think you would be finding an overdose. This is more if somebody is on traditional medications like morphine sulfate, oxycodone, OxyContin, and the big one is fentanyl patches. Fentanyl patches are a 72-hour fentanyl patch is over 100 millimorphine equivalents. And we've all seen those patients where the previous patch is still on, or 3 patches are on, or some patients even put the patch in their mouth and chew on it. These could all result in an opioid overdose. And you have the power to save a life with naloxone. This is what it looks like. This is naloxone nasal spray. You can also inject it. It comes as an IV injection. It comes as a intramuscular injection. But in general, we have naloxone nasal sprays. And you put it in the patient's nose and you press the plunger. There's no second spritz, so don't do a test spritz. For some reason, when people use naloxone, there's like this temptation to do a little test spritz. But no, just put it right in the patient's nose and push that plunger. If you think the patient has an opioid overdose and they lost pulses and you're waiting for 911, I would recommend that you start CPR, but also administer naloxone. If there's 2 people there, you can delegate. And if it's just you, I would actually spray naloxone first and then start CPR. This really does save lives, and we should all know how to do it and be ready to do it. You saw those, we have 125,000 opioid deaths per year. Many of those are in healthcare settings. That eclipses COVID deaths. That eclipses motor vehicle deaths. That eclipses all of the deaths in U.S. foreign wars since Vietnam. This is the epidemic of our era, and it is not unlikely, a non-zero chance that you're going to encounter an opioid overdose, especially as we see more opioid use disorder in our long-term care settings. I would love to say that when you start buprenorphine, it's a perfect world and the cravings are maintained and nobody uses again. That's not the case at all. People get severe cravings, even when their cravings are maintained or they miss a dose of buprenorphine, or maybe just an old acquaintance comes in to visit them and brings some fentanyl with them and they decide to have a slip to use these drugs. It's very dangerous to have opioid use disorder, even when your cravings are maintained, and we've got to have naloxone around. I want to wrap up with stigma. And the reason I want to talk about stigma is because the one way we can do our patients a disservice is to think of them as addicts, to think of them as junkies, to think of this as a moral failure. That is absolutely not the case. Opioid use disorder is a chronic brain disorder. When you first use an opioid, you get a dopamine effect. You get a euphoric high. But after a few months of being on opioids, the dopamine effect goes away. People aren't getting high anymore. They get a glutamate effect. Glutamate is the neurotransmitter associated with OCD, associated with compulsion. Those people who have to check the door handle 10 times before they can leave the house. This is how people with opioid use disorder feel. They must find an opioid. They must get it. And until that craving is treated with, could be buprenorphine, but usually an opioid, until that craving is treated, they don't feel normal. And so you see all this maladaptive behavior around opioid use disorder, things like stealing, things like lying, things like being sneaky, that gets it this bad rap, that gets it this stigma. And for some reason in society, we're still able to have this stigma. You see TV shows like Cops, or you see, a movie where the quote unquote junkie is lurking in the shadows, trying to lure someone in. We've really done our patients a disservice as a society with painting this as some moral failing, when in fact it's all about neurotransmitters. It's a chronic brain disease that any of us could be subject to if we were exposed to opioids and those brain pathways change in our brain. And so we have to lead the way, in healthcare, just like we got smoking off our campus, just like we got healthy foods into our cafeteria, we have to lead the way in treating this as a chronic brain illness like it is. And the way that the experts recommend that we do this is by using person-first language. So person-first language, if I work in the emergency department. I love law enforcement. We are so tight with our law enforcement officers, but in general, law enforcement is not using person-first language. They are saying, this is a substance abuser, this is an opioid addict, they're here with narcotics. It's kind of the language of punishment. And when I'm in the room and I'm with law enforcement and they're using the language of punishment, and I'm saying things like, oh, I see you're having cravings from your opioid use disorder. When was the last time you used? What did you use? Have you sought treatment for it? The patient pivots towards me. They pivot away from law enforcement. They pivot towards me. They feel heard. They feel invited. They feel like, hey, we're in a medical setting. Maybe I can start treating my disease. And so person-first language is this idea that you're not defined by your disease. You're not an addict. You're not an alcoholic. You're a person with opioid use disorder. You're a person with alcohol use disorder. And it is, of course, a little bit tricky because anyone who's ever been to an AA meeting or an NA meeting sees that the people with opioid use disorder will call themselves addicts. They'll say, hi, I'm Bobby Redwood and I'm an alcoholic. And that's okay in that setting. It's just like African Americans have reclaimed the N word and they say, we're going to actually use this word that is demoralizing, that is denigrating, and we're going to reclaim it and use it as a word of empowerment. People who have opioid use disorder or alcohol use disorder can do that. They can retell their own story and use those as empowering terms. But we as medical professionals do not do that. We use words like this: person with opioid use disorder, disease instead of drug habit, a person living in recovery instead of an ex-addict, a person arrested for a drug violation instead of a drug offender, someone who's substance dependent or substance tolerant instead of hooked. And all of us say something in this right-hand column. This is not to shame you, but the reason I think this chart is interesting is because when you see something in the right-hand column, you can ask yourself, well, why is this word on the right-hand column? Why is this something we should not be saying? If you think of the word drug habit, right? A habit makes it think of something that you're choosing to do, something that, I don't know, I might have a cookie habit or an M&M's habit. This is just very different than that. This disease and these drugs actually rewire your brain in a way where it's a compulsion. And so we want to name it like the disease that it is. The other big one with buprenorphine is medication as a crutch or substituting one addiction for another. Those are old-fashioned concepts. This medication is fundamental to treating opioid use disorder. In fact, the success rates of treating opioid use disorder without something like buprenorphine or methadone are very, very poor. Cold turkey is not an option. In alcohol, it seems like it is sometimes an option. In opioid use disorder, it really isn't. And patients don't relapse. They have a setback because the model isn't total abstinence from opioids for life. The model is, sure, you're going to have some use, but when use occurs, let's find out why it occurs, and maybe we can come up with a plan for next time this happens that it won't occur. And when you have your patients in long-term care settings, that's the other thing I really want to emphasize here is treatment for opioid use disorder is not only the medication, it's also going to regular meetings. It's also having a peer recovery coach. It's also having a counselor. we really talk about comprehensive treatment for opioid use disorder, and it's more than just medications. So in summary, before we get to questions, buprenorphine minimizes cravings, it prevents overdose, it saves lives. You're going to see a lot more patients on it, and you should celebrate that. That means we're making progress in our opioid epidemic. Transitions of care to long-term care settings need to be smooth, with policies focused on complete handoffs, early med rec confirmation, and specifically availability of buprenorphine to make sure that a patient doesn't go into withdrawal if that med is unavailable. Alcoholics Anonymous, Narcotics Anonymous, recovery coaches, therapy, etc., are all fundamental aspects of a patient's recovery. So if you see a patient who's on buprenorphine alone and they're struggling, that's something that you could suggest to your medical director or suggest to their family members. Hey, do they have a peer recovery coach? Do they have a sponsor? Do they go to community meetings? It takes a village. This is, I say, a family disease. It's not just the patients who suffer, but our families suffer, our communities suffer, and it takes a community approach to get people real care. And then disruption of medications for opioid use disorder can result in patient withdrawal or suffering. So you do want to make sure that the patients are on the appropriate dose and they're getting their medications. And like we talked about, overdoses are much more common with pain control opioids, things like oxycodone, OxyContin, hydrocodone, than a maintenance medication like buprenorphine. Methadone you can actually overdose on methadone, but again, that would be less common in a long-term care setting. That's usually more of a clinic setting or a hospital setting. And then finally, sometimes we are the barrier to best care. So practice using person-first language, speak out against stigma. And when you feel like you really have it down, when you're saying opioid use disorder, when you're saying that, this is a chronic brain disease, not a habit, now it's time to share it to your peers. If you're orienting a new colleague, if someone's new to long-term care, take 5 minutes out of your day to talk about stigma and person-first language. Your patients will thank you dividends. You are welcoming them into the healthcare setting. All right, I know we have a tight timeline today. We're now open for questions. I'm going to stop sharing and pass the mic back to Stacy and Tony, and we'll answer your questions live.
Oh, thanks, Dr. Redwood. That was really an excellent presentation. So again, if you've got questions, you can feel free to put those in the chat, or you can unmute yourself, or if you're on the phone, *6 will do that same thing. And again, if you'd like to ask a question of Dr. Redwood personally live, you're certainly welcome to do that. So we'll just give folks a minute to maybe think of some questions. And while we're doing that, I'm going to try to find the link, but Superior Health has a wonderful Shine a Light on Stigma campaign. And we'll see if we can get that in the chat, but that is just another opportunity to practice stigma reduction and to actually either you personally or even your organizations signing the pledge that to help to promote and increase awareness of the negative kinds of consequences that stigma has on our residents and staff, actually, for that matter.
Dr. Redwood, what have you seen as far as successful practices in the long-term care setting? Anything that's standing out to you? Any champions in this area right now?
I feel like that's kind of a plug, Stacy. The best champions have naloxone on them. I want all healthcare providers to carry naloxone. And if anybody wants a little homework project today, you come to a webinar and get some homework, go to the pharmacy and buy naloxone. It's over the counter. It's $40 for a 2-pack. First of all, you'll be a superhero because you'll have in your purse, in your glove box, on your work bag, something that can save a life. Not just at work, but at the soccer game, at the high school musical. I mean, it's out there. But more importantly, well, maybe not more importantly, equally importantly, you'll feel some stigma, actually. You'll walk into that pharmacy, and it's kind of a long walk to the counter to buy naloxone. All eyes are on you, Dr. Redwood. You have opioid use disorder. You are an addict. You are going to buy Narcan. I mean, it's intense, that experience. And of course, you don't have opioid use disorder. You're part of the solution. But as you walk away, you just had a little taste of what our patients feel every single day when they seek healthcare in one of our healthcare settings, having opioid use disorder. It's really eye-opening. It really opens the floodgates for empathy and compassion for this vulnerable patient population. It'll be some of the best $40 you ever spent. Even if you never use it, you'll be empowered and you'll have walked in your patient's shoes. So that's what I would recommend. A real thing you can do right now today.
I know too, there are also some places within certain community settings. For example, where I live, I was able to go get naloxone from actually a treatment program facility. And, I was able to get, two packs of it. So that would also be maybe something to check out. And those were at no cost to me. So.
Absolutely. There's a lot of opioid settlement funds coming out, and a big push is to use those dollars for direct distribution of naloxone to patients, their family members, and healthcare providers alike. If you have that resource in your community, absolutely. Take advantage of it and then start ringing the bell so others know about it.
Yeah. I guess the other comment or question I might have is what advice do you have for nursing homes? Well, let's say they have some elderly residents on oh no, now I just lost my train of thought. On a fentanyl patch.
Oh.
What are some steps they could take, or how can they work with their providers to kind of maybe look at, like, are there alternatives for this person?
Yeah, absolutely. So it's a really poignant question, because what happens a lot is patients have some sort of acute pain. They go to the ED, they go to a clinic setting, and they come home with a new prescription. They haven't really been on it very much, and things can change. I'll get back to fentanyl. One of the big ones is actually muscle relaxants. So if someone is maintained on buprenorphine and they're prescribed a sleep aid or a Valium, that is the one time when they could overdose, and you might actually need naloxone for someone who's on buprenorphine. And then for patients who are just on large millimorphine equivalents, they get their new fentanyl patch or a second patch, things like that. As they age, as their kidney function declines, as their frontal lobes atrophy from microvascular disease, all these things, those medications can become more potent. You can start seeing side effects from them, like excessive sleepiness, frequent falls, things like that. And there is definitely a trend to actually treat chronic pain with buprenorphine. And so the way you treat chronic pain with buprenorphine, the primary doctor would do this, but they basically do the same thing. They wait until the patient's in withdrawal and then start buprenorphine, not for opioid use disorder, but just for chronic pain in an opioid tolerant patient. And then we are huge fans of alternatives to opioids as well. And I think so often when someone has a fall, a sprain, a strain, an overuse injury, we forget about the basics, like ice packs, like heat packs, like immobilization, like early physical therapy. Your medical director may have a skill set to do things like trigger point injections, but we have all of the lidocaine patches is a big one. We have all of these elderly friendly alternatives to opioids that I think sometimes we forget about and just jump to the oxycodone. And we do our patients a disservice when we do that. I think of these PRN opioids as a medication of last resort, not of first resort, and always turn to my alternatives to opioids first.
Awesome. Thank you very much for that.
Great question.
All right, so I guess we are at 12:33. Does anyone else have any comments or questions quickly before we end the call for today? This was recorded, so it takes 2 to 3 weeks to get that recording, but this has just been a really excellent and very helpful presentation. So thank you very much.
Thanks for inviting me. Such a pleasure. Good luck, all of you, on your clinical day.
Okay,
Thank you.
Take care, everyone. Thanks for joining us.
And just a reminder, the evaluation link is in the chat. If you would take some time and fill that out, that helps us improve. Thank you, and have a wonderful weekend.
Okay, take care.